Okay, so the difference between seizures and epilepsy is this. Both have seizure episodes. This is chapter 61, page 2017. So both seizure disorders and epilepsy have seizures, all right? The difference is in seizure disorders, you can have multiple. You don't have to have only one. As long as there is a identifiable reason for the seizure, meaning when the doctor runs tests, he or she can identify what caused your seizure. Is that clear? Okay, so that's what we call seizure disorders. So let's say you have a tumor in your brain and it's growing. So of course you're gonna have seizures every now and then because the intracranial pressure is high. So in that case, it's called a seizure disorder caused by a malignant tumor. You understand? Epilepsy, however, is when you have the same more than one seizure with no identifiable cause. They run tests, they could not figure out why you're having seizures. So therefore, you are diagnosed with epilepsy. Management, however, for seizure disorders and epilepsy both include anti-epileptic disorders. However, in the case of seizure disorders, it will also include management of the identified cause of your seizure. Miss Jessica? Okay, very good. So that's the main difference between seizure disorders and epilepsy. Table 61.4. This was inserted here, so I guess I'll include it. So with Alzheimer's disease, which is dementia, this is the most common type of dementia. There are dozens of classifications of dementia. This one constitutes over 60% of all dementia, so Alzheimer's type. We also have vascular dementia, which is usually caused by a cerebral artery blockage. So you have a disorder, whether it's a atherosclerotic disorder or caused by a tumor, for instance, or whatever is growing inside your brain, inside your skull, obstructing blood flow to one or more parts of your brain. That's what we call vascular dementia. Of course, is this acute or chronic? This is, of course, chronic. And then finally, with delirium, this is usually caused by, this is always acute. Delirium is never chronic. So delirium is an acute change in the mental status, change from the patient's baseline, I should say, because it can also occur in people with dementia. They can have delirium as well, which is an acute change again. Whenever we say acute, what does that always entail? Sudden onset. Okay, so let's say the patient usually eats feces. Now the patient is now smearing feces on her face. Okay, so that's an acute change, right? So they usually just eat it, with a spoon and fork. But now the patient is smearing it all over. So is that a change from their baseline? Yeah. Yes. Here are risk factors for Alzheimer's dementia. It's usually associated with age. Although there are early onset cases of Alzheimer's dementia, let's say as early as 60, you may manifest it. And it's also linked to genetics. So for instance, if you have a grandparent or a parent who has dementia, most likely you may have it as well, but there's no guarantee. As described earlier, for vascular dementia, it's usually caused by a vascular disorder, either a congenital vascular anomaly or a growing tumor or atherosclerotic disease. And then for delirium, it's usually brought about by some acute episode, let's say, that causes decreased oxygen or blood flow to your brain. Let's say you had received medications that causes CNS depression, such as anesthesia, for instance, or opioids, or any other drugs that can cause the same. or it could be some diseases as well. Say you go septic or any type of shock, for instance, that will drop blood pressure and therefore decrease perfusion to your brain, then you can have delirium. And these are the other differences. So onset, of course, in dementia, it's chronic. So therefore, development is slow. There are 3 stages of dementia. For vascular dementia, this can be acute, the same as delirium as well. And those are the most important differences between the 3. Let's go to management. It's not mentioned in the table, so let's just discuss it. Based on the etiology, for instance, for Alzheimer's dementia, what do you think is the treatment? Can we stop this from progressing? You can slow it down. However, you cannot stop it. For vascular dementia, however, because it's caused by either a cardiovascular disease, such as, let's say, you have AFib, aflutter, correct? That causes a blood clot to form. So let's say 1 or more parts of your brain was obstructed by a blood clot, similar to stroke. Can this be treated? Yes. So let's say you have hypertension, or let's say you have atherosclerotic disease, or there's a tumor. Can that be treated? Yes. Yes. So is there treatment for vascular dementia? Yes. For delirium, is there treatment for it? No. Let's say the examples I gave you earlier. Let's say you're 81 years old. I gave you anesthesia, and then you went cuckoo after the surgery. Is there treatment for that? Yes. So if things wear off, then delirium will disappear. Patient will go back usually to their baseline mental status. Any question about the 3? Alrighty. So back to seizures. There are many classifications, chart 61-4. I'm only testing the most common type, which is generalized or also called tonic-clonic seizures. Again, chart 61-4, I'm not testing everything. I'm only testing the most common type, which is generalized or also called tonic-clonic seizures. As I mentioned about identifiable causes earlier, these are the usual causes of seizures. Allergies, meaning you have an allergic reaction, can lead to seizures. You have a tumor, as mentioned earlier, you have increased intracranial pressure because of that growing tumor. After head injury, because after head injury, is there also increased intracranial pressure? Yeah, because there's swelling, edema, bleeding inside your brain, correct? Inside your skull. So can that increase ICP? Yes, leading to seizures as well. Cerebrovascular disease, this is example here is a stroke or with vascular dementia earlier. Encephalopathy, or let's say you have meningitis. Those are CNS infections, can also increase ICP. Drug and alcohol withdrawal. So for those who work in hospitals here, what do patients who are on observation for alcohol or drug withdrawal placed on? What drugs are they given around the clock? Ms. Green? Jade, right? Oh, Jade. What? Oh, Tahina?
Yes, methadone.
No, that's okay. That's for opioid withdrawal. No, I mean by alcohol and drug withdrawal. What? Philip? Sorry. Well, that can be treatment. That's an anti-seizure medication, but no, that's the tool that we use to assess for the presence of symptoms of withdrawal. C1. What drugs are they usually placed on round the clock to prevent withdrawal? No, that's the antidote for Have you heard?
What is starting, Professor? What is starting?
It's lorazepam. You've heard of lorazepam? Okay, Ativan. So benzodiazepines, or some facilities may use diazepam, but most facilities use lorazepam. Fever. So I had multiple seizures as an infant. I was a sickly child, so my mom told me she had to, every time I had some infection, I throw a high fever, and each time I would throw a seizure and then crap on her as well. Severe hypertension, especially when your blood pressure is over 200, that can lead to increase in ICP as well because of increased blood volume, and then therefore can lead to seizures. Severe hypoxemia of any cause, and metabolic conditions, let's say hypoglycemia, hyponatremia, because hyponatremia can lead to cerebral edema. Kidney injury because of severe, what do you call that condition again? When your BUN creatinine is really high. What is that condition called? As a result of AKI? There's a term for that.
End-stage renal?
No.
When you have that
Correct. Yeah, you have so much. Yeah, you have so much waste products.
Yeah.
No.
Uremia something. Uremia something. It's uremia something. Uremia something. It's too much waste in the body. What's it called?
What, you have too much what?
Urine creatinine. It's uremia or something. It's a C.
Can't remember the term now.
No, me either.
I'll tell you later when it comes back to me. All right. So let's go to manifestation. So as I mentioned, we only testing the generalized seizures. Yes, okay, very good. Azotemia. The manifestations of tonic-clonic seizures are the following. Most people, especially those who have epilepsy, may have a aura. This is called the pre-ictal phase, because there are phases in seizures. We have the pre-ictal, we have the ictal, and then we have the recovery. So it's unique to each patient. It's not the same everywhere. The book may mention a few of the common auras or pre-ictal manifestations, but it's always unique to each individual. Okay, some people may hear or smell something, see something. They may have tics, for instance, prior to the seizure episode, or any of these manifestations mentioned here. I remember Stella, a girl I went to kindergarten with. No, more like first grade, I think. Well, she was a classmate since kindergarten. But I remember in first grade, she would have these tics wherein she'll make sounds. She'll start saying, right. So that will last for a few seconds, and then because we got so used to it already, no, we just look, and then she's gonna seize, and then the teacher would just keep going, which is really heartless, and then she'd topple over and then seize on the floor, and then we just watch her, and then just put a pillow and then let her lay there, and then until she recovers. Well, that was how the school handled it. What am I supposed to do? I was in first grade. And then I don't know what happened to Stella. She disappeared in second grade. Never saw her again. Oh, I remember a lot. Yeah.
I remember.
Okay, we can share about your experience later.
Okay.
So once the seizure episode begins, or this is now the tonic-clonic period. It starts with rigidity of the entire body. Every single muscle of the body becomes rigid, meaning intense muscle contraction, followed by alternating muscle relaxation and relaxation. Relaxation and contraction. So the patient has any aura, whatever aura they have, and then they'll go into rigidity and then followed by jerking movements, which is alternating relaxation and contraction of the muscles. The tongue may be injured. If it falls out of place, they can bite it, chew on it, and there could be bowel and bladder incontinence, and usually lasts for about 2 minutes. If it's lasting 5 minutes or longer, that could be life-threatening. We call that status epilepticus. And then during the post-ictal phase, the patient's movements stop, and then the patient relaxes and usually goes into deep coma. They can stay like this for a few minutes, maybe up to 30 minutes, or it could be a few hours, depending on the person. So each person has a different seizure experience. Most of them will report these after the seizure and usually have no recollection of the event unless they have had this before and they find out that they had a seizure because they have, of course, they're on the floor, for instance, instead of on their bed, or they have unexplained injuries, and then they'll say, oh, I must have had a seizure again. Diagnostic findings, of course. If it's a seizure disorder, will we find a cause? A seizure disorder. Yes. Remember, there are causes listed here. So if it's a seizure disorder, we can identify, right? We can identify it from one of these. If we can't find any of these, so what will the patient's diagnosis be? Epilepsy. They must have had to be having epilepsy. They must have had more than one episode of seizures with no identifiable cause. To identify whether or not you had a seizure event, the doctor will order an EEG, electroencephalogram. This will measure the electrical activities of the brain. And of course, the neurologist will interpret the findings. So our responsibilities here is, of course, maintaining safety and knowing when to call 911 or take the patient to the hospital. The following are important assessment findings to take note. Number one is always the circumstances. What preceded the event? Did the patient experience anything prior to the seizure episode? Was there any aura? Okay, of course, most aura is subjective. Unless it's vocal, then we can see it, we can observe it, or we can hear it. What did they do? Okay, meaning what type of seizure did they have? It's usually what the doctors in the emergency room will ask the witness. Types of movements, areas of the bodies involved. If the witness has the skills, then we'll ask them whether or not there were any pupillary changes. And I won't read the whole thing, just read it yourself. Now, the important assessment to note, most important, is the time. Somebody must take note of what time did the seizure begin. Because what did we mention about status epilepticus again earlier? Okay, if it reaches 5 minutes or longer, it can be life-threatening. Patient may die from that seizure. Because imagine if you're doing this for more than 5 minutes. Are you really breathing?
No.
Are you really oxygenating the brain? No. So that can lead to permanent brain damage.
So what do you do if they're not in the hospital?
Well, if it's more than 5 minutes, then you call 911.
But they still already be there.
Again, depends on where did the seizure occur. If it's in the hospital, good. okay, because we have healthcare personnel, but most of these seizures occur outside the hospital. So let me mention the 3 conditions. There are only 3 instances that you call 911. Okay, only 3. Otherwise, if the patient has epilepsy, we don't really need to take them to the hospital today. You understand? Okay.
Yes.
Only 3 conditions. 1, this is the first seizure event. Oh, of course, everybody goes to the hospital if this is the first time you had a seizure. 2nd, you sustained a severe injury because of that seizure. Meaning you cracked your head, let's say you had a seizure coming down the steps. Of course, you're going to sustain injury. So you take them to the hospital. Number 3, if it's status epilepticus, which is again a seizure lasting more than 5 minutes. So therefore, you call 911. What are those 3 again?
If they heard, it's the first time.
First time, serious injury, and then status epilepticus. Okay. Let's discuss seizure precautions. So what are, let's say the doctor admits a patient for alcohol withdrawal. So we place them on seizure precautions, correct? So what are you going to prepare? What are the activities involved when a doctor orders institute seizure precautions? Because the doctor won't write it down. The doctor will just write seizure precautions. And it's your job now to figure out what to do. Okay. So number 1. Okay. So
Placing a bed in the low.
okay, so let's look at it one by one. So for to suction the secretions during the seizure, we should have suction equipment. Do we need oxygen?
Yes.
Okay. So that's a suction catheter. Make sure you have a suction equipment and suction catheter, right? Because you have a suction machine, but then you don't have the tubings or the suction apparatus. Okay, so that's useless. Bed always low position. 3 side rails up. Why not 4?
Because that's restraint.
Very good, children. And if, let's say, there are some facilities that don't have side rails, let's say in long-term care, so you can put a mattress, okay, on the floor. That way, yeah, there's no side rail, so of course they'll fall, and then at least they won't crack their head because there's a mattress, right? Meaning some facilities allow patients to fall, all right? So not all facilities have a hospital bed, meaning they don't have side rail. They have a regular bed, just like you guys have at home, okay? So just a regular mattress with a base, but then no side rails. Do we still put padded tongue depressors? Okay, so no more. We're not supposed to put anything into their mouth anymore. Okay, let's go to epilepsies. We'll go to management later because the management for seizure disorders and epilepsy is the same drug therapy. Epilepsy again is, when do we consider patient as having epilepsy? Okay, no identifiable cause for the seizure. So the patient had an unprovoked more than one episode of seizure activity is not considered epilepsy. Once you have your second and then more, then you have epilepsy without an identifiable cause. Again, these are the other causes in addition to what was mentioned under seizure disorders. Let's go to nursing interventions. Chart 61-5. So this is what you do during a seizure. And then next one is after the seizure. So during, oh, I forgot one more thing. Seizure precautions will include an IV access. So in addition to the pilot side rail, suction, oxygen, what else?
Did you say after the?
Yeah, the mattress, whatever. we need an IV access because can you start an IV access during the seizure? Impossible. Yes. The patient usually has no control. It's not like the patient does seizure and then well, no, they just seize and then they have no purposeful movement. Okay, unless you set it up. Say you guide the hand toward the IV and then yeah, and then they'll pull it out. Okay, but you set them up. I don't have to read it. You read it on your own. The important thing here is, let's say this one. Do not attempt to put anything into their mouth. Yeah, and then before, during my time, we were still using because that's what our textbook said. No, we put a padded tongue blade. Right, and then it resulted in these. So we've had broken teeth, and we thought, oh no, it's okay, unfortunate, but we stopped doing that, and now. So do not restrain the movement, just guide the movement safely. So let's say the patient's having a seizure right at the edge of the yellow strip on the train platform. So do you just, well, the book said don't restrain. So just watch them and then they fall into the train tracks. What do you do? Okay, so you guide them safely, okay? And put their head to the side so they don't aspirate from their secretions. After the seizure, so keep them onto one side, allow them to rest. They'll be expected to be confused. And again, some short-term amnesia. They have no recollection of events immediately before the seizure. Here's one for patient care, patient-centered care. So this is a QSIN information. So make sure you read this one about females. And here's another QSIN. So gender and then age. Prevention. Prevention is usually if the patient has seizure disorders, meaning we have identifiable causes, then you control the underlying cause. But for management, it's all drug therapy. Table 61-5. Which ones? Okay, let me highlight. Don't worry, I'll zoom back after I highlight. So I'm only highlighting the most commonly prescribed anti-seizure medications in acute care facilities and long-term as well. So you've got Tegretol or carbamazepine. What's testable here? Side effects. Side effects or toxic effects. So for Tegretol or carbamazepine, clonazepam and Klonopin, and gabapentin is Neurontin, levetiracetam is Keppra, phenobarb, I forgot the brand name. Phenytoin is Dilantin, topiramate or Topamax, and then valproate, which is still valproic acid. Got it?
Wait, go down.
You got the first two?
Yes.
Yeah. Oh, you're only touching the one part?
Yep. But feel free to study all. Okay. Now, in acute care, let's say the patient came in after a seizure. The drug they'll use, if the patient had a seizure, so they'll put you on an IV infusion of either phenytoin or levetiracetam. Okay, so either phenytoin or levetiracetam. Clear? Phenytoin is the most commonly prescribed anti-seizure medications for both seizure disorders or epilepsy. So do we need to know all the side effects of phenytoin? Because of all the drugs listed here, this is the most commonly used or prescribed. May go back up here. Now, as far as surgery, I won't test surgery because you won't see patients typically undergoing surgery, unless of course it's a seizure disorder. Let's say you have a tumor, so yeah, they'll undergo surgery. However, if it's epilepsy, there's really no long list of patients who underwent surgery and were cured by surgery. Okay, so there's really the statistics still say 9 out of 10 patients are on medications. For how long?
For life.
For life. Of course, if it's seizure disorder, not epilepsy, the patient may only be on the anti-seizures for how long? While they still have the underlying cause. So let's say they still have the severe hypertension, they still have the tumor, or they still have during the first few months after stroke or head injury, for instance. You see what I'm saying? Okay. So the success of seizure management depends on medication compliance. So the patient must understand how to take their drugs, why they're on these drugs, and because these are long-term, so do they need to know the side effects? Okay, especially the toxic effects, because most drugs, let's say phenytoin alone, if you have time, look at the drug book and go under drug interactions. Phenytoin has probably, if it's a drug book, the drug book is this big, right? It probably has 3 pages long. So whenever I'm giving phenytoin to a patient, I space it out from other drugs because I know, or I assume it's going to interact with every other drug there is.
Level 2
yeah, but your textbook doesn't give you the normal ranges. Okay. So for the exam, I'll provide you with the normal range. Okay. And then I'll give you, of course, whether it's high or low. Okay. Well, you determine that based on the numbers. Because it interacts with almost every medication there is, can the blood levels of these drugs be messed up?
Yeah.
Whenever you take another drug?
Yeah.
Yes. One more thing, with phenytoin, aside from the gingival hyperplasia, which is, your gums will be irritated, swollen. If a patient is on tube feeding, which we concluded enteral feeding, the enteral feeding must be held for 1 full hour before and after giving phenytoin. Right? It must be held 1 hour before and 1 hour after giving phenytoin. Are we clear? The drug book tells you.
Because of the 2?
I'm not really sure, but that's the instruction on the drug book. For enteral feeding, yeah, patients receiving enteral feeding, I guess it interacts with the formula. As far as safety in the community, patients depends on the state. Each state has its own laws regarding, probably not Florida. Florida is very constitution friendly, so I doubt they'll even give blind patients driver's licenses. That's not true. I mean, I'm just saying that because the last time I was in the Florida DMV, when I renewed my license, the guy next to me, he was wearing a veteran's hat. No, World War II veteran hat. So very old, Navy, you can tell, from the hat. So he's a very old sailor. And then the person behind the counter was telling him, okay, read to me again that line. It was just the first few lines. Everybody can read that, right? The only thing you can't read is the bottom two, right? This person missed every one. And then the DMV officer just still said, oh, that's okay. Don't hurt yourself. Here's your license. I don't want to be around that guy when he drives.
Florida people don't know how to drive.
Usually why?
You know how they take their test in Florida to get their license? Like the shopping center parking lot.
They go around the cone.
That's it? Yeah.
Like on the TV, they
I
go
got my
around the
license.
cone.
Why are we letting you drive? Hold on. My license, she was on her cell phone having a conversation.
Oh, she was chilling.
That's true though, because I got my initial license there too.
Okay.
All right. So let's go to teaching. So here are teachings for people with epilepsy. So this is now long-term medication therapy. Could be select all that apply. Very good. This one, chart 61-6. Okay, let's go to status epilepticus. Is this a life-threatening emergency? Yes. Okay. There are only 2 drugs approved to stop the seizure. One is lorazepam, the other is diazepam. So Valium or Ativan, not both, one or the other. So this is 5 minutes or longer. Or if the patient has multiple seizure within a 30-minute period, meaning did they have a full recovery from the previous seizure? No, the brain hasn't fully recovered yet. And then they have another one. Okay, so that's what we call status epilepticus. One of my nephews, ironically, his dad, no, this is my great nephew because his dad, Max's dad, is my nephew. Yeah, so he's my great nephew. Yeah. So in his first year of life, the poor kid had seizures nonstop. So he's had probably at least 4 or 5 status epilepticus episodes. His mom's Russian, very religious, and she went to every saint, in every church, and it suddenly just went away. So she really attributed it to just divine intervention, because no doctor could help him. No, every medication he's already on, they did all these tests, nothing. So he was diagnosed with epilepsy, and then suddenly, so for me, really, it was just a matter of they really got the right drug combination. But then, according to Alicia, it was really God that healed Max. A good-looking kid, half Russian, half Filipino. Imagine that. Oh. He is 5'10" to 5 taller than his great uncle. Yeah. Yes.
Oh, I was gonna say baby Mariah.
No, he's still on medications as far as I know. Yes. They, based on the drug levels, they do the adjustments, of course. But he's never had a seizure since he turned 2 years old. Yeah, but he's still on. Yeah.
Why don't they try to stop?
Well, he's already in high school now. He's
So why don't they try to stop the medication?
The doctors wouldn't take the risk, because of his history.
Yeah, the history of status, more than
Yeah.
status.
I know, but if he hadn't.
It could be the medication sustaining him from not having a status.
I don't know. I'm not a doctor, and I'm not a parent.
Maybe the minute they take him off, they'll have a seizure.
You know, my friend, like when she got pregnant, they just stopped when she having.
Oh.
Yeah, so sometimes they say like your body just changes.
Any question about the drug? So again, IV, lorazepam, or diazepam. That's it. Yeah, that's it for
Today?